Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's June 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlights articles. Our Editor's Choice is an original article that describes the successful application of fetoscopic therapy for severe pulmonary hypoplasia and congenital diaphragmatic hernia in 2 patients cared for at Mayo Clinic between January and August 2017. It is authored by Dr. Rodrigo Arano and a multidisciplinary team from Mayo Clinic in Rochester, Minnesota. Congenital diaphragmatic hernia with severe pulmonary hypoplasia is a life-threatening anomaly that affects 1 in 3,000 live births and is associated with a poor survival rate. Defects in the diaphragm cause abdominal viscera to herniate into the chest, with attendant compromise in lung development. Preclinical and clinical studies suggest that occluding the trachea improves lung growth and vascular remodeling. Prior experience has suggested that fetuses with severe isolated congenital diaphragmatic hernia, abbreviated as CDH, have higher survival rates after fetoscopic tracheal occlusion, abbreviated as FETO, than those who were treated only postnatally. FETO has thus been proposed and used as a therapeutic approach in CDH with severe pulmonary hypoplasia. In the 2 cases in this report, severe CDH diagnosed by ultrasonography demonstrated extremely reduced lung size and herniation of the liver into the chest. Both patients underwent FETO at 28 weeks. At the time of intervention, no maternal or fetal complications were observed. Following FETO, increased fetal lung growth was observed in both fetuses. The occluding balloons placed in the trachea were removed successfully in the first patient at 35 weeks by ultrasound-guided puncture, and in the second patient at 32 weeks by ex utero intrapartum therapy to airway procedure. Postnatal management followed standard of care with patch therapy for the diaphragmatic defect. At hospital discharge, 1 patient was breathing normally, while the other required minimal nasal cannula oxygen. Salient aspects of this report include the following. First, as pointed out by Ruano et al., FETO requires a prenatal and postnatal multidisciplinary team approach comprising expertise and specialists in fetal regenerative medicine and surgery, pediatric anesthesiology, pediatric surgery, pediatric otolaryngology, neonatology, obstetric anesthesiology, and maternal fetal medicine. Second, the management protocol requires dedication and expertise in each phase, including pre-fetal evaluation, family care conference, and simulation and briefing, the fetal procedure itself, post-fetal evaluation, pre-balloon removal simulation and briefing, fetal endoluminal tracheal balloon removal, and postnatal follow-up. Third, the clinical experience with FETO provides a paradigm for future fetal regenerative medicine services focusing on improving prenatal care for a spectrum of congenital conditions beyond congenital diaphragmatic hernia, including spina bifida, lower urinary tract obstruction, and severe cardiac anomalies. This article is accompanied by an editorial by Dr. Scott Waldman from Thomas Jefferson University in Philadelphia, Pennsylvania. Dr. Waldman notes the refinement of prenatal diagnostic methodologies has enabled applying regenerative approaches in utero to address and remedy severe congenital conditions before birth, thereby averting or attenuating processes that will lead to chronic debilitating conditions. Dr. Waldman underscores that essential to the success of implementing fetal care is the proficiency and coordination of a multidisciplinary team acting in unison to address the concomitant needs of both the mother and the fetus. He also discusses how preclinical observations can stimulate clinically relevant approaches in regenerative medicine, and how clinical observations led to fetal care for CDH, namely the clinical observation that fetuses with laryngeal atresia exhibit an increased lung volume and augmented alveolar number. Dr. Waldman concludes that the rollout of fetal regenerative medicine service lines, as illustrated at Mayo Clinic in this article, provides a prime example of how next-generation solutions can be implemented in clinical practice. Our first highlight is an original article that evaluates the influence of exercise capacity and body mass index on 10-year mortality in patients with heart failure. It is authored by Dr. Paul McCauley from Winston-Salem State University in North Carolina and colleagues from several U.S. and international institutions. Analyses in this study were performed on a sample drawn from a population of more than 40,000 participants in the Henry Ford Exercise Testing Project, the FIT project, who were studied at Henry Ford Hospital and affiliated medical centers in Detroit, Michigan between January 1, 1991 and May 31, 2009. Data on these participants included body mass index BMI and metabolic equivalence METs achieved on a treadmill exercise test. From this population, the authors identified 774 men and women with a history of heart failure at the time of the test, a BMI of at least 18.5, and cardiac ejection fraction data. The mean age of these participants was 60 years, with 48% Black Americans. Patients were grouped by BMI categories by Kaplan-Meier survival analyses and stratified by exercise capacity. Associations of BMI and exercise capacity with all-cause mortality were assessed using multivariable adjusted Cox proportional hazards models. During a mean follow-up of 10 years, 380 patients, 49%, died. Kaplan-Meier survival plots revealed a significant inverse association between BMI category and survival for exercise capacity less than 4 METs, but not for an exercise capacity greater than 4 METs. These findings, at least for subjects with low exercise capacity, are consistent with the obesity paradox phenomenon, wherein increased BMI may be associated with lower mortality. The authors also observed a strong inverse association between exercise capacity category and total mortality. Compared with the higher exercise capacity reference group, patients with lower exercise capacity had a 1.4-fold higher mortality risk. Each 1 MET increase was independently associated with an 11% decrease in mortality. The authors concluded that maximal exercise capacity modified the relationship between BMI and long-term survival in patients with heart failure, consistent with an exercise capacity obesity paradox dichotomy as observed in the short term in previous studies. The second highlight is an original article based on the Rochester Epidemiology Project that examines the relationship between vitamin D levels and all-cause mortality risk. It is authored by Dr. Daniel Dudenkopf and colleagues from Mayo Clinic in Rochester, Minnesota. The authors identified all initial serum 25-hydroxy vitamin D measurements in persons aged 18 years and older residing in Olmsted County between January 1, 2005 and December 31, 2011. Patients were followed up until their last clinic visit in Olmsted County as an Olmsted County resident until December 31, 2014, or until death, whichever came first. Analyses were based on a population that exceeded 11,000 patients, and after a median observed follow-up of approximately 5 years, there were 723 deaths. 123 were cancer-related, 125 were circulatory-related, 159 were respiratory-related, and 316 with other causes. The final model for all-cause mortality included age, sex, Charlson Comorbidity Index score, index month, race, ethnicity, and vitamin D categories, and the interaction between race and ethnicity and serum 25-hydroxy vitamin D. Based on the univariate analysis, the authors observed a greater risk of death in males, in older subjects, and in those with a higher Charlson index score. For low 25-hydroxy vitamin D levels, whites were at a much higher risk of death than patients of other races or ethnicity. A strong association between 25-hydroxy vitamin D concentrations of less than 20 nanograms per ml and all-cause mortality was observed in white patients, but not observed in patients of other race or ethnicity. The authors conclude that white patients with 25-hydroxy vitamin D values of less than 20 nanograms per ml have had a greater all-cause mortality than those with 25-hydroxy vitamin D values of 20 to 50 nanograms per ml. White patients had greater mortality associated with low 25-hydroxy vitamin D values than patients of other race or ethnicity. Values of 25-hydroxy vitamin D greater than 50 nanograms per ml were not associated with an increased risk of all-cause mortality. The third highlight is an original article that employed a blinded chart review between January 1, 2000 and December 31, 2009 to determine how providers screen for and subjects endorsed suicidal ideation at medical appointments in the year preceding death in Olmsted County, Minnesota. It is authored by Dr. Tanner Boomersbach and colleagues from Mayo Clinic in Rochester, Minnesota, and Kaiser Permanente in San Diego, California. This study also employed the Rochester Epidemiology Project for case and control selection. In a prior study, these authors challenged the notion that utilization of healthcare is greater in suicide decedents. Their prior study demonstrated that suicide decedents, compared with age and sex-matched controls, did not significantly differ in exposure to healthcare in the 12 months, 6 months, and 4 weeks before death. However, a limitation of that study and others is that such studies did not evaluate how providers asked about suicidal ideation. In the present study, with 66 confirmed cases of suicide and 141 control subjects, less than half of suicide decedents in the year before their deaths and less than 10% of controls were screened for suicidality. Although most providers failed to screen either cases or controls for suicidality, they were more likely to screen individuals who eventually committed suicide, irrespective of mental health diagnosis. When screened, less than 60% of eventual suicide decedents ever endorsed suicidality, whether in response to a questionnaire or direct provider questioning. The findings in this study show that most suicide decedents were not screened for suicidality in the year before death, and when they were, more than 40% did not express suicidal ideation at any point. Those suicide decedents who express suicide ideation did so in the absence of any discernible pattern. Specifically, none did so in the final appointment before death. The results support the conclusions that any patient expressing suicidal ideation is at an increased risk of suicide, even though most eventual suicide decedents will not endorse suicidal ideation. Thus, even 100% compliance by care providers with inquiring about suicidal ideation may not identify most suicide decedents. These findings bring into question the effectiveness of current screening methods at medical appointments in the year before death in preventing most suicides. You can access these highlights and editor's choice articles free of charge during the entire month of June when you visit our Mayo Clinic Proceeding website at www.mayoclinicproceedings.org. You will see other free content and articles published online ahead of print. You can also find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find author interviews, 60 seconds video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on our home page as well as through iTunes. You will also find our Pioneers and Legends video interview featuring Dr. Donald Schultz. And finally, our website lists many news stories that are based on articles published in Mayo Clinic Proceedings. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.